Welcome back to Beyond the Stethoscope, the podcast for general practitioners.
Hello, Dan.
Especially welcome to all you busy GPs and GP registrars getting ready for those fellowship exams. We're glad you could join us.
Yeah, great to be here. Today, we're diving into a really common condition, something you definitely see day in, day out, and it's absolutely vital for exam prep too, chronic obstructive pulmonary disease, COPD.
Exactly. We're planning a comprehensive look, really trying to get into the details beyond just the basics, focusing on what makes a difference in diagnosis and, managing your patients effectively.
It's a major topic. COPD has a huge impact. It's a leading cause of illness and, sadly, death worldwide. And here in Australia, it affects a really significant chunk of the adult population, particularly over 45. So yeah, getting a solid grasp is crucial for any GP.
Definitely. And to make sure we're giving you really solid, clinically useful info, our discussion today is based heavily on the COPD chapter from the latest, the 8th edition of John Murtaugh's General Practice, a go-to resource for many of us.
That's right. We're pulling out the key knowledge from Murtaugh, laying it out hopefully in a way that's detailed but also, easy to follow. The aim is to give you a really thorough grounding from pathophysiology right through to practical management and maybe touching on some typical case presentations.
Yeah, we want to help you connect the dots, not just list facts. Okay, where should we start? Actually, thinking historically, it's quite amazing Tobias Venner back in the 17th century was already warning about tobacco.
It's fascinating, isn't it? Some quite vivid language about its effects.
Really sets the scene for understanding COPD's main cause today.
Absolutely. It shows that people have known for centuries that breathing in toxins is bad for the lungs. Okay, so let's get to the modern definition. The GOLID guidelines define COPD as, well, common, preventable, and treatable. That's important.
Preventable and treatable, good points to start with.
Yes. And it's characterized by persistent airflow limitation that isn't fully reversible, it's usually progressive, and it's linked to this enhanced chronic inflammatory response in the airways and the lungs themselves, mostly from inhaling noxious stuff like smoke.
So the key is it's not fully reversible, and it's progressive. Structural changes.
Exactly. It's a structural disease. The inflammation leads to actual physical changes in the lungs and airways. It's not just temporary.
Right. And it's more than just their lung function at one point in time.
That's right. The GOLID definition also really highlights how exacerbations, those flare-ups and other health problems, comorbidities, play a big role in how severe the disease is overall for that particular person.
Okay.
And age-wise, while you can see it earlier, it typically shows up clinically in the 5th, 6th decades or later, usually after significant exposure.
Okay, clear definition. Irreversible airflow limit, structural changes. Now, causes. Smoking is the obvious one, right?
Yeah.
But what else?
Yeah, smoking is definitely number one. Cigarette smoke is the main driver behind both chronic bronchitis, that chronic cough with phlegm, and emphysema, which is the destruction of the alveoli, the air sacs.
But not all smokers get it, do they?
No, interestingly, only about maybe 10 to 15% of long-term smokers develop clinically significant COPD, which tells us there's probably some individual susceptibility, maybe genetic factors, other things involved too.
So what are those other things?
Well, worldwide, a huge factor is exposure to biomass fuel smoke, burning wood, dung, crop residues for cooking or heating, especially in developing nations.
Right. Less common here, maybe, but still possible.
Still something to consider, yeah. Then there's air pollution, both outside air and indoor pollution from things like unvented stoves. Also, a history of bad chest infections, especially as a child, might increase the risk later on.
Okay.
And certain jobs, of course, exposure to dusts, chemicals, cadmium, silica, coal dust are known offenders.
And genetics, you mentioned that.
Yes, definitely genetics. The classic one is alpha-1 antitrypsin deficiency. That's strongly linked to getting emphysema early, sometimes even if you've never smoked.
Ah, right. That's important for family history.
Crucial. And maybe bronchial hyperresponsiveness, being more sensitive, might play a small role too.
It's definitely more complex than just smoking. And what about passive smoking? Being around smokers?
Oh, absolutely. Long-term passive smoking significantly ups the risk. Some studies say it doubles or even quadruples the risk over a lifetime.
Wow.
Yeah, really hammers home why smoke-free policies are so important for public health.
Okay, so we know what it is, what causes it, how do we spot it? The COPDX plan starts with C-confirmed diagnosis. What clinical clues should make us think COPD?
Usually it starts at the patient's story, the history. The classic symptoms are chronic, progressive breathlessness, often worse with activity at first, a chronic cough, maybe with sputum, maybe dry. and sometimes recurrent wheezing or chest tightness.
So anyone over 35, smoker or ex-smoker with those symptoms.
You've got to consider COPD. Absolutely. And don't forget those other risk factors we talked about, even non-smokers with heavy exposure.
Okay. And what might we find on examination?
The exam can give clues, especially later on. Early COPD, the exam might be pretty normal.
Right.
But as it gets worse, you might see faster breathing. Maybe they're not expanding your chest fully. Signs of hyperinflation, that barrel chest look, maybe hyperresonant sound when you tap the chest.
And listening.
Diminished breath sounds are common. You might hear wheezes, too.
What about those old terms, pink puffer and blue bloater? Are these still useful ways to think about patients?
They're classic descriptions, yeah. They paint a picture of two ends of the spectrum. The pink puffer often has more emphysema, very breathless, but keeps decent blood gases until late, hence pink. Often thin, using extra muscles to breathe.
Okay.
The blue bloater usually has more chronic bronchitis, features lots of mucus, tends to get low oxygen and high CO2 earlier, so they might look cyanotic, blue and sometimes fluid overload, edema, bloater.
But people can be a mix.
Oh, definitely. Most patients have features of both. It's a spectrum. And in very advanced disease, you might see signs of right heart failure, cor pulmonale, like raised JVP, swollen ankles.
So the history and maybe the exam point towards it, but we need proof, right? Objective tests.
Absolutely critical. Clinical suspicion isn't enough. You need pulmonary function tests, and you also need to rule out other things that cause similar symptoms. Asthma is a big one, bronchiectasis, heart failure. And be cautious diagnosing COPD just based on cough in someone without a smoking history, unless maybe you're thinking alpha-1 deficiency because of family history.
And the scary thing is people can lose a lot of lung function before they even feel bad enough to come in.
Tragically, yes. Up to 50% sometimes, which really highlights why we should think about screening people we know are at high risk.
A sobering thought. Okay, investigations. What's the #1 test?
Spirometry, no question. It's the gold standard for diagnosis, checking severity, and monitoring COPD over time.
What does it measure?
It measures how much air you can breathe in and out and how fast you can blow it out. The key numbers for COPD diagnosis are the FEV1, that's the forced expiratory volume in 1 second, and the FVC, the forced vital capacity, which is the total amount of air blown out.
So what's the diagnostic criteria?
We look at the ratio of FEV1 to FVC. If that ratio is less than 0.70 after the patient has used a bronchodilator, like salbutamol.
After the reliever puffer.
Yes. And their FEV1 itself is less than 80% of what we'd predict for their age, height, and sex, then that confirms airflow limitation consistent with COPD. The fact it doesn't fully reverse with the bronchodilator is key to distinguishing it from typical asthma.
Got it. FEV1 FEC ratio under 0.7 post-bronchodilator and FEV1 under 80% predicted. How do we then stage the severity?
Right, once diagnosed, we stage it. The Australian guidelines often use a simple system. Mild is FEV1 60 to 80% predicted, moderate is 40 to 59%, and severe is less than 40%. The International Goldie guidelines have 4 stages based on FEV1% predicted. Grade 1 mild is 80% or more. Grade 2 moderate is 50 to 79%. Grade 3 severe is 30 to 49%. And grade 4 very severe is less than 30%.
So slightly different systems, but both based on FEV1. Important to know both.
Yeah, useful to be familiar with both as they help guide treatment choices and give an idea about prognosis.
What about a chest x-ray? Is that always needed?
It's usually part of the initial workup. It can actually look normal, even with quite bad COPD.
Really?
Yeah. But later on, it might show signs like hyperinflation, flattened diaphragm, big gaps behind the breastbone. More importantly, though, the X-ray helps rule out other things causing the symptoms, lung cancer, pneumonia, heart failure. And it can show comorbidities.
Okay, so useful for ruling things out. What about blood gases, ABGs?
Not routine for everyone, especially early on, but definitely important if the disease is severe, say FEV1 less than 40%, or if the patient seems unwell, maybe confused or cyanotic, suggesting respiratory failure.
And what do they tell us?
They show the oxygen level, PaO2, the carbon dioxide level, PaSO2, and the body's acid-base balance. In advanced COPD, you might find low oxygen and high CO2, critical information in acute situations.
I remember hearing about DLCO, the diffusion capacity test. Where does that fit in?
The gas transfer factor, or DLCO. It measures how well oxygen gets from the air sacs into the blood. It's often reduced in COPD, especially with emphysema, because the lung tissue is damaged.
And that helps distinguish it from asthma.
It can, yes. In asthma, the DLCO is usually normal or sometimes even high, whereas in COPD, especially emphysema predominant, it's typically low. It helps paint a clearer picture of the type of lung damage.
Any other tests we might consider?
Well, an ECG could show signs of strain on the right side of the heart. That's core pulmonale in advanced cases. Sputum culture if you suspect infection, especially resistant bacteria. A full blood count, FBE, to check for anemia or polycythemia. Sometimes chronic low oxygen makes the body produce too many red blood cells.
Right, the hemoglobin might be high.
Exactly, and definitely test for alpha-1 antitrypsin deficiency in younger patients, non-smokers with emphysema, or those with a strong family history.
Okay, that's a thorough workup. Spirometry first, then other tests as needed. Let's move to management. The O in COPDX. Optimize function. What are the main goals here?
The big goals are simple, really. Make people feel better, help them do more, reduce those flare-ups, improve their overall health, and hopefully help them live longer.
And how do we achieve that?
It boils down to three main pillars. Number one, stop smoking. Number two, medications. And number three, non-drug approaches, especially pulmonary rehabilitation.
Let's use that smokes checklist again. S is smoking cessation non-negotiable, right?
Absolutely paramount. It's the only thing proven to slow down how quickly the lungs decline.
Okay. M is medication. What are the main drug classes for stable COPD?
Primarily bronchodilators. They open the airways, make breathing easier, reduce wheeze. We have short-acting ones, Sevas like salbutamol, terbutaline, and Samas like ipratropium.
For quick relief.
Yes. And then long-acting ones for maintenance lebas like formoterol, salmeterol, indicaterol, vilanterol, and lamas like tiotropium, glycopyrronium, meclidinium, aclidinium.
Okay, LABAs and LAMAs.
And then inhaled corticosteroids, ICS, have a role for some patients, usually combined with a LABA. Plus, don't forget vaccines, flu, and pneumococcal.
Right. Cocal is oxygen. When do people need long-term oxygen?
LTOT is for people with severe, persistent low oxygen levels. The usual cutoff is a resting PaO2 of 55 millimilli Hg or less, or oxygen saturation, SpO2, of 88% or less on room air when they're stable.
And they have to have stopped smoking.
Yes, absolutely critical. Stable disease and quit smoking for at least a month usually before assessment. It can also be considered if oxygen is slightly higher, but they have signs of complications like cor pulmonale or polycythemia.
Okay. K is for comorbidity. Why focus on other conditions?
Because people with COPD often have lots of other health issues, heart disease, osteoporosis, anxiety, depression, sleep apnea, reflux. These things heavily impact their symptoms, their function, their risk of flare-ups, and their overall outlook.
So treating those helps the COPD too.
Definitely. Managing comorbidities is a crucial part of holistic COPD care. It can make a huge difference to quality of life.
Makes sense.
Yeah.
LP is exercise and rehabilitation. Tell us more about pulmonary rehab.
Pulmonary rehab is fantastic. It's a structured program, usually involves exercise training tailored to the person, education about managing their COPD, maybe nutritional advice, psychological support.
And it works.
Oh, yeah, the evidence is really strong. It improves exercise capacity, reduces breathlessness, boosts quality of life, cuts down exacerbations and hospital visits. Really should be offered to almost all symptomatic COPD patients.
Good to know. And finally, S for surgery. Who gets considered for that?
Surgery is for a very select few with severe disease. Things like bulectomy, removing large non-functional air sacs called bullae that squash good lung tissue, or lung volume reduction surgery, LVRS, taking out the most damaged bits of lung to help the rest work better. And then lung transplant is the ultimate option for some very severe cases.
But these are specialist referrals, obviously.
Absolutely. Needs careful assessment by a respiratory team.
Okay, that smokes checklist is a really useful framework. Let's dig into the medications a bit more. Bronchodilators, short-acting versus long-acting. When do you start which?
Short-acting ones, SABAs or SAMAs, are basically relievers, used as needed for sudden breathlessness or wheeze. Quick onset, but doesn't last long.
Right, the blue puffer type thing.
Exactly. Now, if someone's getting symptoms regularly or having flare-ups, that's when you move to maintenance therapy with long-acting bronchodilators, LABAs or LAMAs, or sometimes both. They provide round-the-clock bronchodilation.
So persistent symptoms usually means a long-acting inhaler.
Generally, yes. If symptoms are only very occasional, maybe just a short-acting one is enough. But for most people needing regular treatment, a LABA or a LAMA is the starting point.
What's the difference between LABAs and LAMAs? Do you choose one over the other?
They work differently. LABAs stimulate beta-2 receptors, relaxing airway muscle, LAMAs block muscarinic receptors, stopping the signal that constricts airways and also reducing mucus a bit. Both are effective at improving symptoms and reducing exacerbations.
Any reason to prefer one?
Well, some studies suggest LAMAs, especially tiotropium, might be slightly better at preventing exacerbations than LABAs alone, particularly in certain patient groups. But often the choice depends on the individual, how they respond, side effects, other health issues, ease of use, cost. Sometimes using both together gives an added benefit.
Okay. And what about inhaled corticosteroids, the ICS? You said they're for specific patients.
Yes, their role is quite targeted in COPD, unlike in asthma, where they're often first-line controllers. In COPD, ICS are not used alone. They're added on top of long-acting bronchodilators, usually a LABA, specifically for patients with moderate to severe COPD who keep having exacerbations despite good bronchodilator treatment.
So their main job is preventing flare-ups.
Exactly. The main goal is reducing exacerbation frequency and severity. But, importantly, they don't stop the underlying decline in lung function over time, and there's that increased risk of pneumonia we need to keep in mind.
Right. So it's a trade-off.
It is. You have to weigh the benefit in reducing exacerbations against the potential risks, especially pneumonia.
So who specifically should get an ICS added? What are the criteria?
Generally, guidelines suggest considering adding an ICS to a LEBA if the patient has an FEV1 below 50% predicted and they're still having frequent exacerbations, say, two or more moderate ones needing steroids or antibiotics or one needing hospital admission in the last year, even though they're already using a LEBA or LAMA-LABA combo.
Okay, FEV1 50% plus ongoing exacerbations.
That's the typical profile. And sometimes, for the most severe group with persistent exacerbations, triple therapy, LEMA, LEBA, and ICS altogether might be needed. But you always need to review if the ICS is actually helping and consider stopping it if not, or if side effects are an issue.
Makes sense. Okay, briefly then, the prevent deterioration part of COPDX. We've hit smoking cessation and vaccines hard. Anything else key there?
Well, regular exercise and pulmonary rehab are vital for maintaining function, which indirectly helps prevent deterioration. Avoiding triggers like pollution or workplace dust is important too, and getting that long-term oxygen right for hypoxemic patients improves survival. Managing exacerbations will also limits their long-term damage.
A good point. Now, develop support network and self-management plan. Rehab is part of that support. What else is involved?
COPD is tough, chronic, often progressive. It affects quality of life significantly. So support is crucial. That means involving family, carers, maybe patient support groups, and definitely the multidisciplinary
I know
team.
that team.
Could be respiratory nurses, physios for breathing exercises and clearance techniques, OTs for daily living adaptations, social workers, psychologists for anxiety or depression, dietitians, pharmacists for medication reviews. The GP often coordinates this team,
And the self-management plan.
empowering the patient, giving them an individual plan how to recognize worsening symptoms, when to use reliever meds, when to start steroids or antibiotics if they have a rescue pack, how to use their inhalers correctly, lifestyle advice. It gives them control.
Absolutely. Okay, final piece. Manage exacerbations. How do we know what's a flare-up and what's the first-line approach?
An exacerbation or flare-up is basically a sudden worsening of their usual symptoms. More breathless, more cough, maybe more sputum, or the sputum changes color, becomes purulent. It happens acutely over hours or days.
Okay.
First steps are usually increasing the short-acting bronchodilator, use more puffs more often, maybe via a spacer or a nebulizer if severe. If they're hypoxemic, give controlled oxygen, aim for SATs of 88-92%, not too high initially.
Why not too high?
Risk of worsening CO2 retention, hypercapnia in some severe COPD patients. So you start low, maybe 24-28% via Venturi mask or 1-2L via nasal prongs, and monitor closely, ideally with blood gases.
Right, and steroids.
Systemic corticosteroids, usually oral prednisolone, about 30-50 milligrams daily for 5 to 7 days, are standard for moderate to severe exacerbations. They speed up recovery and reduce relapse risk. A short course, 5 days, is often as good as longer courses now.
And antibiotics. Always.
Not always. Many exacerbations are viral, but consider antibiotics if there are clear signs of bacterial infection, specifically increased sputum volume and increased sputum purulence, especially if accompanied by increased breathlessness, the classic Anthonyson criteria.
Okay. What about hospital admission?
Need to admit if symptoms are severe, if they can't cope at home, if they're very breathless even at rest, confused, cyanotic, if oxygen levels are very low, or if they have significant comorbidities or aren't responding to initial treatment. An NVDV non-invasive ventilation might be needed in hospital for respiratory failure.
We've covered a huge amount. Let's try and boil it down. For the GPs and registrars listening, what are the absolute must-know takeaways about COPD?
Okay, key points. COPD yields common irreversible airflow limit, mainly from smoking. Diagnosis needs spirometry showing that post-bronchodilator FEV1 FEC 0.7. Management cornerstones are stop smoking, use long-acting bronchodilators regularly for symptoms and exacerbation prevention. Consider ICS for selected frequent exacerbators. Pulmonary rehab is vital. Treat exacerbations quickly and appropriately. And always manage those comorbidities and support the patient with self-management.
Fantastic summary. This is bread and butter stuff for general practice, but the nuances are key, especially for exams. Definitely encourage you all to look at that Murtaugh chapter and the guidelines for more depth.
Mm-hmm.
So, a final thought to leave everyone with. Given how common COPD is and how much function can be lost before diagnosis, how can we in primary care get better at spotting those at-risk patients earlier? How can we really shift the curve on their long-term outcomes? Something to ponder. Thanks for joining us for this deep dive on Beyond the Stethoscope.
Thank you.
We'll catch you next time for another important topic in general practice.